This is NCLEX audio, exam preparation content reviewed and approved by a licensed registered nurse before publication. Nothing here is medical advice or clinical guidance, and we have no affiliation with the NCSBN or any state board. Now let us get into it. 7:42 in the morning, Saturday, Riverside General Emergency Bay. Frank Delgado, 68 years old, retired high school baseball coach. Brought in by paramedics after his 16-year-old granddaughter Sofia called 911. Right-sided facial droop, right arm drift, slurred speech, alert and agitated. Blood pressure on arrival, 188/102. Frank's last documented normal behavior, 7:15 in the morning, when Sofia watched him pour his coffee without any difficulty. 45 minutes from that moment to the emergency bay.
Okay. 68-year-old male. History of hypertension on lisinopril. New onset right facial droop, right arm weakness, slurred speech. Sofia, the granddaughter, she is the one who called 911. He kept waving her off in the ambulance, kept telling everyone he was fine.
Walk me through fast, out loud.
F is facial drooping. One side of the face droops or goes numb. You ask the person to smile and one side does not respond. A is arm weakness. The person raises both arms and one drifts downward. S is speech difficulty. Slurred, garbled, missing words, or no speech at all. T is time. Time to call 911.
What time goes in the chart?
Symptom onset?
If the symptom was not witnessed directly.
Last known well, 7:15. When Sofia watched him pour the coffee normally,
That is the clock. Not when Sofia got scared. Not when dispatch answered. Not when the ambulance pulled in. When was Frank last completely, entirely, 100% himself? That moment is everything. Everything after it is the window.
45 minutes from last known well to right now. We are inside the 3-hour window with time left.
Get me his full neurological assessment. NIH Stroke Scale. Go.
Jake spent 9 minutes with Frank. Frank spent at least 6 of those 9 minutes trying to sit up, waving his hand at the door, and insisting this was unnecessary. Blood pressure in the room, 190/104. Right arm drifted within 10 seconds of being raised. Right lower face drooped clearly when Jake asked him to smile. Speech was dysarthric. The words were there, but blurred, like a mouth that belonged to someone else. Frank understood everything. He answered yes and no questions by nodding. He just could not form clean words back. Down the hall, Sofia sat alone in a plastic chair with her phone face down on the seat beside her. She had not touched it since she sat down.
NIH Stroke Scale score is 12. Level of consciousness is intact. He is awake and following commands. Gaze is intact. No visual field cut I could identify. Right facial droop, moderate. Right arm drifts with some effort against gravity. He can still move it. Right leg holds better than the arm. No ataxia. Sensation diminished on the right side. Mild aphasia. He understands, but output is dysarthric. 12 puts him in moderate stroke territory.
What does a score of 12 tell you about eligibility?
Does not exclude him. The cutoff for the extended window is above 25. He is at 12.
Walk me through the standard exclusion criteria for alteplase. Go fast.
Hemorrhage on computed tomography. Blood pressure above 185/110 that cannot be controlled. Platelet count below 100,000. International normalized ratio above 1.7. Heparin use with an elevated partial thromboplastin time. Major surgery within 14 days. History of intracranial hemorrhage. Active internal bleeding. Blood glucose below 50 milligrams per deciliter.
He is in the extended window, 3 to 4.5 hours, if we lose any time on this end. What exclusions apply specifically there?
Age 80 or older, out of the extended window. NIHSS Stroke Scale, above 25. Oral anticoagulant use regardless of what the INR actually reads. And the one that trips people? Prior ischemic stroke combined with diabetes. Not stroke alone, not diabetes alone. Both together remove the patient from the extended window. Either one by itself, the patient can still be eligible.
Frank is 68. No prior stroke documented. No diabetes in his history. Anticoagulants?
Just lisinopril, no anticoagulants.
So right now he appears eligible, pending imaging.
Right. And Maria, listen, the computed tomography is not back yet, but look at this presentation. Unilateral deficit, no headache reported, no vomiting, he is alert and oriented, hypertension history which fits ischemic perfectly, sudden onset. This is a textbook ischemic stroke. Every single sign points the same direction. And I know the number. Approximately 1.9 million neurons die per minute in an untreated large hemispheric stroke. We are burning time. I want to get the alteplase order started now, so when the scan comes back clean, we are not waiting another 15 minutes for the pharmacy to process it.
How does a hemorrhagic stroke present?
Elevated blood pressure, focal neurological deficits, sometimes a thunderclap headache, worst headache of the patient's life. Vomiting, rapid deterioration. He does not have the headache. He denied it.
Frank has been insisting he is fine since the paramedics picked him up. His granddaughter said he was waving her off before he got in the ambulance. He spent 6 of 9 minutes trying to get you out of his room. How reliable is his symptom history right now?
He could be minimizing. He is clearly embarrassed that Sofia caused all this.
What else?
High pain threshold. Scared and not tracking his own symptoms. Distracted by the agitation of being here against his will.
Can any combination of clinical signs reliably tell you ischemic from hemorrhagic without imaging?
No, I know that. Both present with elevated blood pressure. Both present with focal deficits. The thunderclap headache is classic for subarachnoid hemorrhage, but it is not universal. You need imaging. I know you need imaging.
What happens if you give alteplase to a patient with a hemorrhagic stroke?
The drug converts plasminogen to plasmin, breaks down fibrin. The clot the body formed to seal the ruptured vessel wall. You dissolve it. The bleed expands. Intracranial pressure builds. Brain tissue gets compressed.
And then?
Herniation. The patient dies from the drug designed to save them.
That has happened.
I know.
No scan, no drug. That is the rule. 1.9 million neurons a minute is real. And it is not a reason to skip the one step that tells you which drug saves this patient and which one kills him. The computed tomography is not a delay. It is the decision.
I will be ready the second it comes back.
Then get ready. Do not touch anything until you have that result in your hand.
16 minutes after Jake's assessment. Computed tomography of the head. Without contrast. No hemorrhage identified. No early signs of large territory infarction. Radiologist conclusion, negative for acute hemorrhagic process.
No blood. Clean scan. He is ischemic. Now we move.
Blood pressure right now.
188 over 102. We need it below 185 over 110 before the drug goes in.
Why not push it all the way down? Get it to 120, 130. Less pressure on the vessel walls.
Because of the penumbra. The area of brain tissue surrounding the infarct core, the dead zone. It is not dead yet. It is alive but not functioning. It is being kept perfused by collateral vessels that branch around the blocked artery. Those collaterals are pressure dependent. They only carry blood because the systemic pressure is high enough to force it through. If I lower Frank's pressure aggressively, those pathways close. The penumbra dies. I make the stroke permanently larger than it had to be.
Give me an image for that.
A river with a dam across the main channel. The town downstream is losing water. But there are small streams that branch around the dam. They're still barely reaching the town. Those streams only flow because the reservoir pressure upstream is high enough to push water through the narrow side channels. If I reduce the pressure in the whole system, the side streams go dry. The town loses its last supply. Frank's penumbra is the town. The collaterals are the side streams. His elevated blood pressure is the reservoir keeping those streams open.
So for ischemic stroke, no alteplase, what pressure do you tolerate before intervening?
Up to 220 over 120. Below that threshold, you do not intervene unless there is another independent reason, acute heart failure, aortic dissection, something that demands pressure reduction on its own.
Before alteplase goes in.
Get it below 185 over 110. That is the threshold. You cannot administer the drug above it.
During infusion and for 24 hours after?
Below 180/105, the full 24 hours.
3 situations, 3 numbers.
Ischemic, no alteplase. Tolerate up to 220/120. Pre-alteplase, get below 185/110. Post-alteplase for 24 hours. Stay below 180/105.
And if that computed tomography had shown blood?
Everything flips. Hemorrhagic stroke. Target systolic below 140. Aggressive lowering. The penumbra logic does not apply because there is no ischemic mechanism. The danger is the expanding hematoma, the pressure of the blood on surrounding tissue. Lower pressure means less force driving through the rupture.
Same room, same patient, same arrival blood pressure. Different scan, different drug, different target, different outcome if you reverse them.
And the scan is the only thing that separates those two paths.
The attending confirmed eligibility. Intravenous labetalol brought Frank's blood pressure to 182/98. Frank weighed 88 kilograms.
Pharmacy has the order. Standard alteplase dose, 1 milligram per kilogram. Frank is 88 kilograms, so we are at 88 milligrams total.
0.9.
Sorry?
0.9 milligrams per kilogram. Not 1.
That is 1/10 of a milligram difference per kilogram. It comes out basically the same.
For Frank, it does not. 0.9 times 88 is 79 milligrams. 1 milligram times 88 is 88 milligrams. You just gave him 9 extra milligrams. That is the window where intracranial hemorrhage risk starts climbing. The 90 milligram cap exists for exactly this reason. 0.9 is the number. Say it until it is boring.
0.9 milligrams per kilogram. Maximum 90 milligrams total. 10% as an intravenous bolus over 1 minute. 90% infused over 60 minutes.
Now go hang it.
One note for the record. Alteplase is not the only treatment for ischemic stroke with a large vessel occlusion. Mechanical thrombectomy, a catheter-based procedure that removes the clot directly from the vessel, is now recommended for eligible patients with major cerebral artery blockages. The window extends up to 24 hours from last known well in selected cases with favorable imaging. Alteplase and thrombectomy are not mutually exclusive. Eligible patients may receive both.
Bolus is in. Infusion running. 60 minutes on the clock.
What are you watching for?
Neurological changes every 15 minutes. New headache, that is the first alarm. Drop in level of consciousness. Asymmetric pupils. Any sudden worsening of the existing deficit or any new deficit appearing on the other side.
Why headache specifically?
Hemorrhagic transformation. Alteplase breaks down fibrin. If a vessel wall is fragile anywhere in the territory, the drug can convert an ischemic stroke to hemorrhagic mid-treatment. New headache during infusion is the warning sign. I stop the drip immediately. Not slow it, not wait to reassess. Stop and call the team.
Blood pressure during infusion.
Every 15 minutes. Keep it below 180/105. Any reading above that, I notify the team. I do not adjust independently.
His lisinopril, his regular blood pressure medication.
On hold. Nothing by mouth right now. Swallowing has not been assessed yet. And no antiplatelets, no anticoagulants for the full 24 hours post-alteplase. No aspirin. Nothing that adds to bleeding risk until we have repeat imaging at 24 hours.
Then what?
If the repeat computed tomography at 24 hours shows no hemorrhagic transformation, aspirin gets started. That is when antiplatelet therapy is safe, not before.
Why 24 hours specifically?
Alteplase clears fast, half-life under 5 minutes. But the vessel walls it acted on take time to restabilize. Adding aspirin too early risks any microbleeding expanding into something larger. The imaging at 24 hours is the safety confirmation before antiplatelet therapy begins.
Maria stood at the doorway for a moment, not watching the pump, watching Frank.
You okay?
I had a patient once. tPA running. Everything looked stable. I had 4 patients that shift, and I went to do a medication pass. Came back 20 minutes later. He told me he had a headache. I thought it was the lights, the monitor, the stress of being here. I stopped the drip 12 minutes later than I should have. He survived. I still count those 12 minutes.
I will check every 5 minutes.
You have 4 other patients.
Every 5 minutes.
She did not argue. 40 minutes into the infusion. Frank's blood pressure, 176/94. Deficit, unchanged. Right facial droop, right arm weakness, dysarthric speech. No new headache, no change in consciousness.
Sofia?
She was in the same chair, phone still face down beside her. She looked up when he came through the door.
Your grandfather is getting the medication. His blood pressure came down to where we needed it. So far, no new problems.
She nodded. She had the look of someone who had been holding a breath for a long time.
His speech? I know what it sounded like when you called 911. I want to explain something that matters. He understood every single thing we said to him. He answered every yes and no question correctly. What the stroke affected was the output, the words coming back out. The input was intact. His brain was receiving information normally. That distinction matters a great deal for what happens next.
She asked if he was going to be okay. Just that. 3 words. Jake had the data ready. He knew the major clinical trial outcomes on alteplase by severity and time window. He knew the functional recovery curves. He had read every major paper in school and could quote the numbers. He looked at Sofia. 16 years old, alone on a Saturday morning. Her parents, 2 hours away. She had sat across from her grandfather going slack on one side, and she had not let him wave her off.
He got here because of you. You learned the signs, and when he told you it was nothing, you called anyway. That part is done. And you got it right.
She said he was so angry at her in the ambulance.
People get angry when they are scared. He will understand what you did. Later, when things are calmer, he will understand.
Jake sat with her for a few minutes. He did not quote outcomes data. He did not explain the mechanism of thrombolysis. He sat there. Then he went back to check the pump. Infusion complete. Frank's blood pressure held below 180/105 throughout. No neurological changes during the 60 minutes. Frank was being transferred to the stroke unit.
Before he goes upstairs, swallowing assessment. Nothing by mouth until he is screened.
Why?
Think about what we just watched. Frank's right arm drifted. His right face drooped. Both of those run on the same cortical motor signals that control swallowing, through the vagus and glossopharyngeal nerves. The stroke that hit his arm and his face ran through the same territory as the muscles coordinating his airway. He is awake. He is nodding at you. He can answer yes and no questions. And he can still silently aspirate the first sip of water straight into his lungs because the pharyngeal coordination is gone and there is no outward sign that tells you. If that happens, I have added aspiration pneumonia to a stroke admission. That is one of the leading causes of death after stroke, and it is completely preventable.
What does nothing by mouth include?
Everything. Oral medications, water, ice chips, all of it. If speech therapy cannot evaluate him immediately, I do a bedside water swallow screen. Small sips, watch for coughing, choking, wet or gurgly voice quality after swallowing. Fail to screen, nothing by mouth until formal evaluation. His lisinopril is an oral tablet. If he cannot swallow safely, I need an intravenous alternative, or I hold and call the team. Not crush it, not mix it into applesauce and hope. Hold and discuss.
24-hour monitoring priorities. List them.
Blood pressure every hour minimum, more frequently if antihypertensives are running. Neurological checks, level of consciousness, motor strength, speech, watching for any change that might signal hemorrhagic transformation or edema developing. Blood glucose. Hyperglycemia after ischemic stroke impairs reperfusion and expands infarct size, so we target 140 to 180 milligrams per deciliter. Temperature. Fever increases metabolic demand on already damaged brain tissue and worsens the ischemia, so we treat it aggressively with acetaminophen. Deep vein thrombosis prophylaxis. Immobile stroke patients carry high risk. And repeat computed tomography at 24 hours before aspirin.
Good. Different patient, next week. New onset left arm weakness and slurred speech. What is the very first thing you do before anything else?
Fingerstick glucose. Before imaging. Before the stroke protocol. Before anything.
Why does it go first?
Because hypoglycemia can look exactly like stroke. The brain runs entirely on glucose. No meaningful storage, completely dependent on what is circulating. When blood sugar drops below a critical level, the sodium-potassium pumps in the neurons fail. Ion gradients collapse. You lose function in specific brain regions and it can look completely focal. One arm weak, speech affected, mimicking a vascular event precisely. But the treatment is dextrose, not alteplase. If I skip the fingerstick and go straight to the stroke protocol, I may have delayed by 15 minutes what should have been a 30-second correction.
Glucose is normal. Then what?
Computed tomography without contrast. Rule out hemorrhage. Everything else flows from that result.
3 rules. In order.
Glucose first. No scan, no drug. Know which blood pressure target applies to which situation.
Say them until they are boring. When they are boring, you know them.
I wanted to say something about Sofia. I went in there thinking I was going to explain thrombolysis, give her something clinical to hold on to. And then I looked at her, and she was 16 and alone, and I just sat there instead. I do not know if that was the right call.
She knew 4 letters, and she used them when he told her not to. You told her that was enough. That was the right call.
The T really is the whole thing. Face, arm, speech, those are the recognition. The T is the action. And the T only works if you know what time to put in the chart.
Last known well.
7:15. Coffee poured. Clean. That was Frank's last good moment, and it is the number that determined every decision we made today.
Go finish your charting.
Jake logged out at 7:14 that evening. Before he left, he stopped at the charge desk one more time.
Did Sofia find out her dad called?
Frank asked the nurse to tell her to go get food. Said he would pay her back.
That is something.
It is.
If this episode landed, go prove it. The audio quiz is waiting at NCLEX-RN. 12 questions built directly from what you just heard. Take it. Find out exactly what's stuck and what needs another pass. Subscribe so the next episode is ready when you are. You have been building something real. Keep going.